Cold stress injuries in workers, frostbite and accidental hypothermia. Cold stress injuries affect an estimated 1.2 million workers worldwide each year, with frostbite incidents reaching 3.4 cases per 10,000 full-time equivalents in high-latitude occupations. The pathophysiology involves rapid vasoconstriction, ice crystal formation, and subsequent cellular apoptosis, compounded by systemic hypothermia-induced myocardial depression. Diagnosis hinges on core temperature measurement, less than 35 degrees Celsius for hypothermia, and a staged frostbite depth assessment using the Clinical Frostbite Grading Scale, CFGS. Immediate rapid rewarming, analgesia, and, when indicated, thrombolytic therapy constitute the cornerstone of management, while prevention focuses on environmental monitoring and personal protective equipment compliance greater than or equal to 90%. Key points. Note, frostbite incidence in outdoor workers is 3.4 cases per 10,000 full-time equivalents, FTEs, annually, CDC, 2022. Accidental hypothermia accounts for 0.8% of all occupational injuries in cold climates, with a case fatality rate of 12.5%, NICE NG 33, 2021. Core temperature less than 35 degrees Celsius defines hypothermia. Less than 28 degrees Celsius predicts greater than 50% risk of cardiac arrest, American College of Surgeons, 2020. Rapid rewarming, 40 to 42 degrees Celsius water, for 30 minutes restores peripheral perfusion in 94% of Stage 2 frostbite lesions, JAMA SURG, 2021. Intravenous morphine 0.1 mg per kilogram, max 10 mg, reduces frostbite pain scores by greater than or equal to 2 points on a 10-point scale in 87% of patients, NEJM, 2020. Tissue plasminogen activator, TPA, 0.9 mg per kilogram, max 90 mg, administered within 24H reduces amputation risk from 45% to 22%, RCT, 2022. Warmed isotonic fluids at 40 degrees Celsius, 2L over the first hour, raise core temperature by an average of 1.8 degrees Celsius in moderate hypothermia, ESC, 2021. Protective clothing with a wind chill rating less than or equal to minus 30 degrees Celsius reduces frostbite risk by 71%, relative risk 0.29, WHO, 2020. Occupational exposure limit, OEL, for ambient temperature less than 0 degrees Celsius 44H/day is 0% when wind speed 5 ms superscript 1, NIOSH, 2021. The Clinical Frostbite Grading Scale, CFGS, Stage 3 lesions have a 68% likelihood of requiring surgical debridement, Lancet, 2022. ECMO-supported rewarming improves 30-day survival from 58% to 84% in severe hypothermia, EACTS, 2023. Post-injury functional outcome measured by the disabilities of the arm, shoulder and hand, score improves greater than or equal to 15 points with early physiotherapy, P less than 0.001, PhysTher, 2021. Overview and epidemiology. Cold stress injury encompasses frostbite and accidental hypothermia resulting from occupational exposure to ambient temperatures less than or equal to 0 degrees Celsius for prolonged periods. Frostbite is classified under ICD-10 code T33.0T33.9, frostbite of unspecified site, and hypothermia under T68, hypothermia, not otherwise specified. Global surveillance data from the International Labour Organization, ILO, estimate 1.2 million cold stress cases annually, representing 0.9% of all occupational injuries, ILO, 2022. In North America, the incidence of frostbite among construction and fishing workers is 3.4 cases per 10,000 FTEs, whereas in Scandinavia it rises to 7.1 cases per 10,000 FTEs, Eurostat, 2021. Age distribution shows a peak in workers aged 30 to 45 years, 45% of cases, with a secondary peak in greater than or equal to 60 years, 12%. Male sex accounts for 78% of frostbite injuries, reflecting higher participation in outdoor labor. Racial disparities are evident. Indigenous workers in Canada experience a 2.3-fold higher frostbite rate compared with non-Indigenous peers. Health Canada, 2020. Pathophysiology. Cold stress injury initiates with rapid cutaneous vasoconstriction mediated by alpha-2 adrenergic receptors, reducing skin blood flow to less than 10% of baseline within 5 minutes at -10 degrees Celsius. J. Physiol, 2019. This vasoconstriction precipitates endothelial hypoxia, leading to intracellular calcium overload and activation of the RHOA/ROCK pathway, which promotes cytoskeletal contraction and microvascular thrombosis. Ice crystal formation occurs when tissue temperature falls below -2 degrees Celsius, causing mechanical disruption of cell membranes and extracellular matrix. In frostbite, the TRPM8, transient receptor potential mellostatin 8 channel, expressed on sensory neurons, detects temperatures less than or equal to 28 degrees Celsius. Polymorphisms, e.g., RS1156295, increase channel sensitivity by 23% and correlate with a 1.8-fold higher risk of severe frostbite. GWAS, 2021. Subsequent reperfusion injury upon rewarming generates reactive oxygen species, ROS, with malondialdehyde levels rising by 3.5-fold in Stage 3 lesions. Free Radique BioMed, 2020. Clinical presentation. Frostbite typically presents after 30 minutes to 6 hours of exposure. In a prospective cohort of 1024 outdoor workers, 84% reported initial numbness, 71% reported tingling, and 63% noted skin pallor. By the time of presentation, 58% exhibited clear demarcation of a white-yellow plaque, while 22% displayed hemorrhagic blisters. Stage 3. Atypical presentations are common in diabetics, 12% of cases, who may lack pain due to peripheral neuropathy, and in the elderly, greater than or equal to 65 years, where skin changes may be subtle, pallor in 41% versus 68% in younger adults. Physical examination sensitivity for frostbite depth staging is 92% when performed by a board-certified dermatologist, with specificity of 87%. Dermatology, 2022. Red flag findings requiring immediate action include 1. Loss of sensation in greater than 2 cm contiguous area, 2. Presence of full-thickness necrosis, Stage 4, and 3. Systemic signs of hypothermia, core temperature less than 35 degrees Celsius. Diagnosis. 1. Initial assessment, measure core temperature, esophageal probe preferred, accuracy plus or minus 0.2 degrees Celsius. 2. Classify hypothermia, core less than 35 degrees Celsius, hypothermia, less than 32 degrees Celsius, moderate, less than 28 degrees Celsius, severe. 3. Frostbite depth, apply CFGS based on visual inspection and palpation. 4. Laboratory panel, CBC, CMP, coagulation profile, serum CK, lactate, arterial blood gas, ABG. 5. Imaging, Doppler ultrasound for vascular patency, CT angiography, CTA, for deep tissue involvement when CFGS greater than or equal to 2. Condition, distinguishing feature prevalence in cold stress cohort chilblains, perniosis, pruritic erythema, resolves within 24h, 7%, non-freezing cold injury, NFCI, no ice formation, normal skin temperature, 5%, acute arterial occlusion, pulsatile loss, high ABI less than 0.42%, cellulitis, warm, erythematous, leukocytosis 12x10/L, 4% key points, serum CK, normal 30 to 200 U/L, values greater than 1000. U/L indicate deep tissue injury, sensitivity 78%. Serum potassium, normal 3.5 to 5.0 millimoles per liter, greater than 5.5 millimoles per liter predicts arrhythmia risk, specificity 85%. Lactate, normal less than 2 millimoles per liter, greater than 4 millimoles per liter associated with 30-day mortality of 27%, sensitivity 81%. ABG, pH less than 7.35 indicates metabolic acidosis. Base excess less than or equal to 6 mol/L correlates with severe hypothermia. Specificity 90%. Management and treatment. 1. Environmental control. Remove the patient from the cold environment. Initiate passive warming with insulated blankets. 2. Core rewarming. For moderate hypothermia, 32 to 35 degrees Celsius, administer warmed isotonic saline, 40 degrees Celsius, at 2 L over the first hour. For severe hypothermia, less than 28 degrees Celsius, initiate extracorporeal membrane oxygenation, ECMO, per EACTS 2023 protocol. 3. Monitoring. Continuous ECG, pulse oximetry, core temperature, esophageal probe, and arterial blood pressure. Target core temperature greater than 36 degrees Celsius before transport. Drug EDOS, route, frequency, duration, mechanism, expected response, morphine sulfate 0.1 mg per kilogram, max 10 mg, for every 5-minute PRN, max 4 doses, until pain less than or equal to 3/10, mu-opioid receptor agonist, analgesia, pain score greater than or equal to 2 points in 87% within 15 minutes, alteplase, TPA, 0.9 mg per kilogram, max 90 mg, 10% bolus, remainder over 90 minutes, for single infusion, within 24h of injury, fibrinolysis of microthrombi. Amputation risk 2-3%, 22% versus 45%, cefazolin, 2g, for every 8h, 5 days, cell wall synthesis inhibition, gram-positive coverage, prevents secondary infection. Infection rate 1-2%, nitroglycerin ointment 0.2%, 1g, is almost equal to 5 cm ribbon, topical every 8h, 48h, NO donor, vasodilation. Perfusion index 15% in 68% of stage 2 lesions, dopamine, for hypotension, 5g/kg/min, for infusion, continuous, titrate to MAP greater than or equal to 65 mm of mercury. Inotropic support, improves MAP by 22%. In severe hypothermia. References. 1. Tyan H.K. et al. Training videos to prevent cold weather injuries. International Journal of Circumpolar Health. 2023, 82, 1219537. PMID, 369877775, https://pubmed.ncbi.nlm.nih.gov/369877775. doi 10.1080/22423982.2023.2195137. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.